This is Randy Schell, and I'm making a videocast part 3 of a 3-part series on the topics respiratory anatomy, physiology, and thoracic anesthesia. It's part of our high-yield keyword review at the University of Kentucky Department of Anesthesiology. Our first keyword in part 3 of this 3-part series is anterior mediastinal mass, and the chest x-ray at the far right shows a large anterior mediastinal mass compressing the trachea. These masses can compress vessels like the superior vena cava, the heart, as well as the trachea and bronchi, often worsening when the patient's in the supine position. Pediatric patients can have malignancies like lymphomas and germ cell tumors and thymic tumors that can present as an anterior mediastinal mass. CTs of the chest are very important when you look at those preoperatively and see tracheobronchial compression by a large anterior mediastinal mass of greater than 50% reduction in tracheal diameter. We say that is unsafe to anesthetize that patient with GA. If you do PFTs, flow volume loops, which aren't done very much anymore, but if you did, this would be a variable interthoracic obstruction. That is, as you take a breath in, air moves pretty well on this flow volume loop to the bottom right, but when you try to expire, it is truncated in the flow rates. So expiratory flow rates are reduced with this intrathoracic lesion. Transthoracic echo can be used to look for vascular compression by the tumor. Management of high-risk patients, those with CT evidence of tracheobronchial diameter less than 50%, you might want to consider local anesthesia, obtaining a biopsy of whatever this mass is if possible, and then potentially treating with chemotherapy or radiation to shrink the mass before you take them to surgery. Several principles of managing patients with anterior mediastinal masses is, if at all possible, maintain spontaneous ventilation because negative pressure breathing results in less obstruction than positive pressure breathing. If possible, avoid muscle relaxants. If obstruction occurs while you're anesthetizing the patient in the supine position, think about putting them then in the sitting or lateral or even the prone position to take this mass off the bronchi or the trachea and reduce obstruction. A rigid bronchoscope should be available because if this mass obstructs the trachea or the bronchus, you may need to push that rigid bronchoscope past that obstruction, because simply putting an endotracheal tube in the mid-trachea and try to ventilate is not going to be able to force air past that obstruction in many cases. If it's really bad, cardiopulmonary bypass can be put in standby mode with or without femoral vessel cannulation before you even induce a patient. The next key word is lung ultrasonography and differential diagnosis. And the graphic at the top right shows A lines and B lines, ribs, and pleural lines. So A lines are a representation of the pleura reverberating at different distances from the surface of the chest. So if you have a normal pleura and a relatively normal lung, you're going to see these A lines that are representations of the pleura, and it is an artifact of ultrasound. Lung slide, if the pleura is sliding back and forth with each breath, we say that that's normal, and when it's absent, it's suggestive of pneumothorax. So if you put in a central line and the patient had problems with respiration and saturation and maybe peak airway pressures are up and you wonder, could this be a pneumothorax? Put a lung ultrasound probe on and look for that pleural slide, and when pleural slide is absent, that's suggestive of a pneumothorax. B lines, represented by the far right picture, are representations of an alveolar interstitial process, often like pulmonary edema. And when you have multiple of these B lines radiating across the ultrasound field, that's suggestive of fluid in the interstitium of the alveolus. And interestingly, the presence of these along with pleural slide essentially rules out pneumothorax. So if you're worried about pneumothorax, look for pleural slide, and if you have B lines going through the field, that means that air is not present in the pleural space, blocking ultrasound waves, as they come in because ultrasound doesn't travel well through air. And if you can see these B lines along with pleural slide, unlikely to have a pneumothorax. Pulmonary function test before doing a pneumonectomy. In the past, pulmonary hypertension, a PaCO2 that's above normal at 46 when you start, and you're going to take out a lung, means that this patient could have respiratory cripple postoperatively, requiring tracheostomy and ventilator dependence if you took out a lung and their CO2 was already high. And an FEV1 less than 800 was predictive of postoperative respiratory cripple state. And so we tried to do PFDs in some cases to predict which patients could go through a pneumonectomy without ending up with tracheostomy dependence and ventilator dependence. And if you take out one whole lung and the blood vessels in that lung and force the right ventricle to pump now to only one vascular system, you can imagine how the pulmonary artery pressures could rise and right ventricular failure could ensue. Currently, there's a three-legged stool of pre-thoracotomy respiratory assessment that you can consider. On the far left, respiratory mechanics. What does their FEV1 look like? Is it greater than 40%? Their cardiopulmonary respiratory reserve. Can they climb 2 flights of stairs? How far can they walk in 6 minutes? And what happens to their pulse oximeter readings when they're walking? And is their VO2 max greater than 15 mils per kilo per minute? And can their lungs pass oxygen and CO2 through the parenchyma? And a DLCO, or diffusion lung capacity for carbon monoxide, greater than 40%, and a PaO2 greater than 60, and a PaCO2 less than 45 are good indicators that this patient could go through a pneumonectomy. So these tests are often used as an approach to predict which patients who have lung cancer frequently could undergo a pneumonectomy and not end up as a respiratory cripple or with RV failure. What about stopping smoking preoperatively? There's some short-term beneficial effects and some long-term beneficial effects. The short-term really is saying, well, what if they stop smoking just before surgery, a couple days before surgery? Well, one, you're going to decrease nicotine present in their blood. Nicotine is a sympathetic stimulant, has a very short half-life of about 20 to 30 minutes, and as you know, carbon monoxide is present in cigarettes, and so the carboxyhemoglobin levels, if you stop smoking several days before surgery, will go down, and your oxygen carrying capacity would then go up. Also, remembering that carbon monoxide shifts the oxyhemoglobin curve to the left, if now you don't have that carbon monoxide present, the curve can shift back to the right, which is associated with greater and better delivery of oxygen to the tissues. There is no effect on postoperative pulmonary complications, mucus production, or pulmonary function test improvement by short-term cessation of smoking. So the main benefit of stopping smoking just before surgery is to decrease the nicotine and the sympathetic stimulant effect of such, and the carboxyhemoglobin levels in the patient. You need them to stop smoking for an extended period of time, approximately 2 months or greater, to have the real benefit of reducing postoperative pulmonary complications, like reducing the amount of sputum, increasing the ciliary function of the trachea and bronchioles back towards normal, increasing the FEF 2575 or small airway flow rates, decreasing the closing volume, return of normal immune function, and even hepatic enzyme activity, which is messed up by cigarette smoke. One lung ventilation, what are some of the indications for it? There's some absolute indications, like trying to prevent blood from one lung going into the other lung, or an abscess in one lung, the fluid or pus in it going into the other lung. If you're doing lavage of a lung, obviously the other lung has to be protected from that lavage fluids. And bronchopleural fistula, when there is a communication between a bronchus and the pleural space. If you ventilate that patient, positive pressure ventilation, air can go into the pleura, cause a pneumothorax, for example, collapse that side of the lung. And those are absolute indications for one lung ventilation. Relative indications are what we use one lung ventilation for most of the time, and that's removing part of a lung, thoracic aneurysm surgery, esophageal surgery, and ways to obtain lung separation are shown on the far right, and they include the classic double lumen tube, a bronchial blocker that can be placed down either through a tube or sometimes it's built right into the endotracheal tube. And then occasionally an endobronchial tube can be used for one lung ventilation. That is just passing an endotracheal tube down into a bronchus and ventilating only one lung. Bronchial blockers are one way to obtain one lung ventilation. There's some advantages and disadvantages. This is the advantages shown in green here and the disadvantages shown here in red. The picture shows a bronchial blocker going down through an endotracheal tube out into the left mainstem bronchus and collapsing the left lung in the picture on the top right. Some benefits of a bronchial blocker or advantages: it's easy to recognize the anatomy and to know if the tip of the single lumen tube is above the carina, and so that the bronchial blocker can be placed out and it is going out into either the right or the left mainstem bronchus. When you place a double lumen tube, sometimes the double lumen tube can be placed a little deep and end up on the right side, and you can be confused about where the position is of that double lumen tube and try to isolate, for example, the right middle from the right lower lobe improperly. So a bronchial blocker is also a great device if you've had a difficult airway, because you can place a single lumen tube and then the bronchial blocker through it. A double lumen tube is often more difficult to place. And when you're placing a double lumen tube, it's not uncommon to have the cuff damaged by teeth as it passes through, and then you have a double lumen tube in place without a cuff that's functioning, and you have to replace that double lumen tube. Don't have to worry about that with the bronchial blocker. And at the end of an operation, where you've done lung surgery, for example, or maybe it was a difficult intubation, you don't need to replace the double lumen tube with a single lumen tube if you're planning mechanical ventilation, let's say in the ICU. You can just pull the bronchial blocker and ventilate through the single lumen tube. Bronchial blockers also can be used to isolate at the lobar level. So instead of just the whole left lung or the whole right lung, you can isolate single lobes like the right middle lobe. Problems with the bronchial blockers or disadvantages include the fact that there's a very small channel and you can't suction well through that bronchial blocker. If you convert from 1 to 2 and then to 1 lung ventilation very frequently during surgery, it's kind of more difficult, and the bronchial blocker can get dislodged frequently, especially as the surgeon moves and the patient and pushes on the lung. That bronchial blocker can pop out, maybe back into the trachea, and get dislodged. So more frequent need to reposition and make sure the bronchial blocker is in the proper place is a disadvantage of bronchial blockers. One lung ventilation, how do we set the ventilator? We set with relatively low tidal volumes, 5 to 6 mils per kilogram, and try to keep the peak airway pressure less than about 30 to 35 and plateau airway pressure less than about 25 centimeters of water. Positive end expiratory pressure is frequently used at about 5 centimeters of water to the ventilated lung, but in patients with COPD who already have air trapping and very large lungs, often PEEP is not added. Respiratory rate about 12 breaths per minute, and we put them on the ventilator with these low tidal volumes, relatively low pressures, and attempt to oxygenate with only one lung being ventilated. The next key word is one lung ventilation and hypoxia management. What happens if you switch to one lung ventilation and you have immediate precipitous desaturation, let's say from 98-99% down to in the high 70% or low 80%? That is a really low PaO2. And in that case, you should resume two-lung ventilation, go back to two-lung ventilation, try to figure out what's going on. If it's a gradual desaturation, several steps that you can do. Let's say that you put your double lumen tube down, your saturation starts out at 98%, you go to one lung ventilation, it's 96%, then 94%, then 91%. Now it's starting to get into the critical range, you're in the high 80s, and you're thinking, what can I do next? One, ensure that you're delivering 100% FiO2. Two, check the position of the double lumen endotracheal tube, put your fiber optic scope down and make sure it's positioned properly and hasn't moved. Ensure that your blood pressure and your cardiac output are optimal. Remember that a low blood pressure and low cardiac output can result in a more zone 1 of the lung, because P big A can exceed P little a, the arterial pressure in the pulmonary vessels. So make sure the blood pressure is adequate, make sure that the cardiac output is optimal. Put a recruitment maneuver to the ventilated lung. Recruitment maneuver being relatively high centimeters of water pressure, like 40, and hold it for 7 to 10 seconds. Then you can apply PEEP of 5 centimeters of water to that ventilated lung, except in patients with really bad emphysema. If that doesn't work, your saturation's still low, you can apply CPAP to the non-ventilated lung, the lung that's being worked on surgically. But the first thing you should do is recruit that lung, ventilate it, and then apply the CPAP. Let it fall back down to a CPAP of at least several centimeters of water pressure, oftentimes up to 5 centimeters or so. If this doesn't work, you can use intermittent reinflation of the non-ventilated lung. You just say stop the surgery for a moment, reventilate the lung, and then stop ventilating, and then continue on. Let the saturation come back up, and then when it decreases, go back to ventilating that lung. If you are going to take out a whole lung, one of the things that is most effective is clamping the pulmonary artery and stopping blood flow to go to that lung that's not being ventilated. And so the surgeon may do that, and then your saturation goes right back up, oftentimes to near 100%. And that is a very effective way of reducing hypoxemia during one lung ventilation. Closing capacity, what is it? It's the lung volume at which the small airways begin to collapse. And if you look at the graphic on the far right, you have x-axis age and y-axis lung volume. And it's showing functional residual capacity in the supine position, the lower blue line, and the upper line, the functional residual capacity in the upright position. The important point is this: at age about 44 years in the supine position, the closing capacity is the same as FRC. And even in the upright position at about 66 years, the closing capacity is equal to the FRC in the upright position. So what this says is, as we age, the closing capacity is going up and getting closer and closer to our FRC, and there's going to be more and more airways that are collapsed in the supine position, definitely, and even in the upright position as you get really old. Closing capacity is increased in smoking, COPD, upper abdominal surgery, and as we mentioned, aging. And the closing capacity is the FRC at age 44 in the supine position, and is at the FRC in the aged patient, 66 years old, in the standing position. The next topic is aging and respiratory changes in general, and we'll look at the graphic on the far right, which shows in liters the volume of the lung on the y-axis, and on the x-axis age. And we'll look at the blue arrows showing that one, residual volume, or air that's trapped in the lung that you cannot exhale no matter how hard you try, goes up as we age. That's like the emphysema patient who has trapped air. So the elderly have trapped air and increased residual volume. Because expiratory reserve volume as well as residual volume makes up the functional residual capacity, that's the next arrow we will look at, big blue arrow, and trace it up to the green line, and you can see that FRC is increasing. So the elderly patient has a larger FRC. As we age, FRC goes up. Now, the closing capacity goes up as we age, and the closing volume, such that, as was pointed out earlier, at age 66, the closing volume crosses over with the functional residual capacity, even in the standing position, such that there's lots of small airways that get closed off and air is not going to, and VQ mismatch occurs more as we age. So things that increase residual volume, or air trapped in the lung, FRC, closing capacity and closing volume, and the lung actually becomes more compliant, like an emphysematous lung. I like to think of it as a balloon that just does not want to collapse back on itself. You blow it up, and the elderly lung will not collapse back on itself like a younger lung, and therefore it has more trapped air, residual volume, and FRC. Some things that are decreased as you age are the alveolar surface area, just like an emphysematous patient. The PaLeo2, there are equations that we can use to correct for PaO2 with age. And an elderly patient is expected to have a lower PaO2 because of the VQ mismatching. And laryngeal reflexes are not quite as well. When you do laryngoscopy in a very elderly patient, occasionally you'll even see food particles in the posterior pharynx and even around the glottic opening. And you wonder, why didn't that bother them? Well, their laryngeal reflexes are not as good. So the lung parenchyma of an older patient has a VQ mismatch and an age-related decrease in PaO2. That's a parenchymal change. They have those emphysema-like changes with more air trapped, residual volume, FRC goes up, the gas exchange lung parenchyma area goes down. So you can see why their PaO2 decreases with aging. Their ventilatory control, or the responsiveness to increases in CO2 or decreases in oxygen, are not as great, so that if carbon dioxide goes up or oxygen goes down in an elderly patient, they're not going to ventilate as much. Their minute ventilation will not go up as much. The bellows, their chest wall compliance, isn't often as good. It's often tight, or they may have arthritic changes in their chest wall, and their muscles of their chest wall aren't as good. So the bellows moving in and air out aren't as good. The conducting airways, minimal changes. Airway reflexes, as we mentioned, like the laryngeal reflexes, are decreased. Let's look at a question. Which of the following respiratory changes is most likely to be increased from baseline in an elderly patient 48 hours after they stop smoking in preparation for scheduled surgery? So this is 2 days of stopping smoking. Does their FRC change, their oxygen carrying capacity, their carboxyhemoglobin, their FEV1, or their FEF 2575? So only 2 days of stopping smoking. What's going to increase? Their oxygen carrying capacity, because their carboxyhemoglobin levels go down. So short-term cessation of smoking, carboxyhemoglobin goes down. Next topic is morbid obesity and some of the respiratory changes that occur with such. The lungs of a morbidly obese patient themselves are usually normal with normal compliance, but it's the chest wall that's not so compliant. There's a lot of fat on top of the chest wall, reducing compliance. So they have a restrictive-like ventilation defect such that the ratio of FEV1 to FVC remains greater than that 80%. Their FEV1 is decreased, their FVC is decreased, but if you look at the ratio FEV1 over to FVC, it is greater than 80%. But because they're both decreased, the FEV1 and FVC, we say that is a restrictive ventilation defect. Their FRC, the functional residual capacity, or the gas that is in your lung after an unforced exhalation, normal tidal volume, is decreased. And I like to think of it as their weight of their abdomen, weight of their chest collapses the lung even more. And when you take a breath in and then out, there's less gas left in your lung at the end of an unforced exhalation. So their FRC is decreased. They use more oxygen, they produce more CO2, and because they're producing more CO2, they have to have an increased minute ventilation if they're going to keep their carbon dioxide levels in the normal range. So more work of breathing. They can have chronic hypoxemia and hypercarbia, and the chronic hypoxemia and hypercarbia can cause possible pulmonary hypertension, and we should look for that in morbidly obese patients. When you put them to sleep and they stop breathing, they rapidly desaturate for several reasons. One, their FRC is very low, and they're using more oxygen. Those two reasons are the major reasons for rapid desaturation in the morbidly obese patient when they become apneic. These are the graphic respiratory changes that occur in morbidly obese patients when they assume a supine as well as a Trendelenburg position. At normal tidal volume ventilation, much of the breath is at volumes below the closing capacity. And if you look at the non-obese patient at the far left, you can see that their tidal volume breathing is far above the airway closure where it begins in the small airways. But then you look at the obese patient and you can see that some of their tidal volume here in orange, a lot of it actually, is below the closing volume. And if you take that obese patient and put them from a sitting position into a supine position, boy, that tidal volume breath is even lower below the level at which airway closure begins. And there's lots of airway closure occurring and lots of alveoli that are not getting ventilated, and you get large amounts of VQ mismatch, and that supine obese patient can rapidly desaturate and hypoxia can ensue. And if you take that person who is awake, for example, breathing on their own, put them supine, and then put them in Trendelenburg, for example, put a central line, and you can see why a respiratory arrest could occur very easily in these patients because their tidal volumes are far below airway closure, large amounts of VQ mismatch, hypoxemia ensuing. Obesity hypoventilation syndrome versus obstructive sleep apnea. Let's look at obstructive sleep apnea first. That's the classic male patient who often is obese, who at nighttime has upper airway obstruction, and their significant other, spouse, whatever, says, yeah, in the middle of the night they gasp and choke and they wake up multiple times in the night and then they go back to sleep. So that is the classic obstructive sleep apnea patient. They are not very commonly have pulmonary hypertension, and if they have a sleep study and you monitor them at night while they're sleeping, they have multiple obstructive breathing events per hour, greater than 5. And you say, aha, that's obstructive sleep apnea. Male, obese, gasping at night, waking up multiple times, and on polysomnography, a sleep study, more than 5 obstructive breathing events per hour of sleep. While obesity hypoventilation syndrome, male-female distribution is about equal. Obesity is associated with it. At nighttime, their CO2 goes up and their PaO2 goes down, and it is very severe during periods of rapid eye movement sleep. Their saturation drops, and at night they're not waking up when this occurs. In fact, they're having these periods of hypoxemia and hypercarbia at night. They're not waking up, and your pulmonary artery response to hypoxemia and hypercarbia is constriction. And if a patient has this for an extended period of time, they can develop pulmonary hypertension, which is more common and more severe in patients with obesity hypoventilation syndrome than it is with obstructive sleep apnea. When you monitor these patients with polysomnography or sleep studies, their CO2 goes up during sleep and they desaturate, and this is not explained by apnea or hypopnea. Pulmonary aspiration. What is the risk factors for aspiration and pneumonitis? If a patient aspirates a low pH in a large volume, that puts them at risk for developing actual pneumonitis. So a pH less than 2 to 2.5 and a volume classically of gastric fluid that is regurgitated and actually goes into the lung greater than about 0.4 mils per kilogram is what many books will say, or up to 1 mil per kilogram, somewhere in that range. So the larger the volume, the lower the pH, the higher the risk that that fluid that goes into the lung actually causes a pneumonitis. The treatment when someone aspirates is turn their head to the side, suction their pharynx, put them in a Trendelenburg position, put an endotracheal tube down, suction the endotracheal tube. You're likely going to have to provide positive pressure ventilation with some PEEP to help with their oxygenation. Don't put saline down. Don't put bicarbonate solutions down into the lung. It can push the acid farther out into the alveoli and spread it out into multiple alveoli that were not previously involved. Don't check the pH of the endotracheal tube secretions. When do you do a bronchoscopy? If there's large food particles or things that are obstructing airways, you may need to go down and remove those from obstructing major bronchi. We don't usually give prophylactic antibiotics unless there's evidence of secondary infection develops. We don't give steroids prophylactically, and you can follow that patient up with white blood cell counts and chest x-ray, realizing that the right lower lobe is often the one that's involved with aspiration, and follow them with arterial blood gases. The next topic is transfusion-related acute lung injury, or TRALI. The chest x-ray on the far right shows diffuse pulmonary edema in both lungs of a patient. And that's the way it would look in a patient who has received a transfusion of blood, FFP, or platelets, and within 6 hours after that develops this chest x-ray pattern of pulmonary edema. The diagnosis of TRALI is made when non-cardiogenic pulmonary edema occurs within 6 hours of transfusion of red blood cells, platelets, or FFP. So it's not just red blood cells, it can be FFP or platelets. Non-cardiogenic means that this isn't a heart that's failing, that pressures are building up in the left side of the heart and going back through the pulmonary vessels and pushing water or fluid out into the alveoli hydrostatically. This is a good heart, but the problem is the leaky membranes in this lung. The bilateral chest x-ray infiltrates are consistent with acute lung injury. They're occurring within 6 hours of conclusion of this transfusion. If you have a pulmonary artery catheter in, there's no evidence of high wedge pressures or high left atrial pressures, so this is not a failing heart, and there's not other causes of acute lung injury like inhalational injury of some type. So the explanation is we just transfused them. It's less than 6 hours since we transfused them. Now they have pulmonary edema bilaterally, and it's not their heart. And it occurs in about 1 in 4,500 transfusions. It is a leading cause of transfusion-related mortality. The reaction is between antibodies and white blood cells. And antibodies with white blood cells degranulating in the alveolar units of these patients. So when white blood cells degranulate, they release the stuff that's inside them and damage the endothelium of the pulmonary system and cause this bilateral pulmonary edema. Now it can be a reaction between donor antibodies and recipient white blood cells, or vice versa, but it's really activated white blood cells releasing, degranulating, causing damage to the alveolar interstitium, making it leaky, fluid going in, and it occurring within 6 hours of a transfusion. Now, taking out the white blood cells, leukoreduction, can decrease the presence of anti-leukocyte antibodies, and interestingly, multiparous women or people who have had multiple transfusions are not usually used as plasma donors because their serum can have high titers of leukoagglutinating antibodies and therefore potentially increase the risk of transfusion-related acute lung injury in the patients that are receiving that plasma. The next topic is mediastinoscopy, which is usually performed to obtain lymph node tissue in the staging of lung cancer. The graphic at the far right shows the mediastinoscope in blue in front of the trachea and behind the aorta. Some potential complications of mediastinoscopy include cerebral vascular accident because the scope itself, as you can see in the picture, lies behind the innominate artery, and it can pinch the innominate artery against the sternum and stop blood flow going into it. Now, the innominate artery divides into the right common carotid artery and the right subclavian artery. So if we're monitoring blood pressure on the right side and it goes away, we worry that the mediastinoscope has compressed the innominate artery. And if blood's not going to the right subclavian artery, it's probably not going to the right common carotid artery, and a cerebral vascular accident could ensue. So some form of monitoring of blood pressure in the right upper extremity and pulse in the right upper extremity is done during mediastinoscopy. Sometimes A-lines, sometimes putting a pulse oximeter probe on that side, sometimes putting a blood pressure cuff, or a combination of several of those to monitor for compression of the innominate artery. Pneumothorax can occur. Hemorrhage, as a biopsy is taken of what we think is a lymph node. Sometimes it has been a vessel and bleeding can ensue. So hemorrhage, oftentimes these patients will have a couple good IVs placed before we start. Erroneous diagnosis of cardiac arrest. If you're monitoring the pulse from the right side, the scope occludes the innominate artery, the pulse goes away, and you think it's a cardiac arrest, but really it's compression of the innominate artery. Another thing that can occur is bradycardia because of stretching of the vagus nerve or the trachea by the scope itself. So if a patient suddenly becomes bradycardic, think maybe the scope is stretching the vagus nerve or the trachea, and if you just have them pull the scope back, the bradycardia often goes away, sometimes requires anticholinergic treatment. But the main complication that we worry about with mediastinoscopy, other than bleeding, is this compression of the innominate artery and loss of pulse and blood pressure on the right side. The next topic is apneic oxygenation. Apneic oxygenation can be used for bronchoscopy, microlaryngoscopy, to provide a quiet surgical field when you're doing procedures like laser resection of airway tumors. And one of the ways that it's done is a general anesthetic with neuromuscular blockade, an oxygen catheter placed just above the carina, and gas, oxygen that is, insufflated at 10 to 15 liters per minute after the patient has been denitrogenated and oxygenated with 100% FiO2. So you can think of oxygen flowing in without the lungs moving. You can obtain quite satisfactory oxygenation with this apneic oxygenation methodology for quite a long period of time, more than 30 minutes. But because you're apneic, the CO2 will build up over time, and we usually limit our apneic periods to about 5 minutes or so. The CO2 classically builds up in the first minute at about 6 millimeters of mercury, and every minute thereafter about 3 to 4 millimeters of mercury. At least that's what we classically teach, such that you could see that if 5 minutes went by, the first minute CO2 would build up 6, the next 4 minutes would be 4 for each minute, 16 plus 6 would be about 22 millimeters of mercury in the first 5 minutes. So it is satisfactory ventilation that limits the periods of apneic oxygenation. As the CO2 builds up, catecholamines are secreted and ventricular arrhythmias can ensue. The next topic is carbon monoxide, which can be obtained through smoke inhalation, incomplete combustion of heaters and cars, and in the operating room, desflurane in a dry CO2 absorber can form carbon monoxide. We breathe it back through our circle system. It can bind to our hemoglobin and cause problems. Oxyhemoglobin dissociation curve is shifted to the left by carbon monoxide. Patients that have carbon monoxide poisoning develop headaches and nausea, restlessness, confusion, and eventually can go on to coma. The diagnosis of carbon monoxide poisoning is a blood gas that's put through a co-oximeter. Why? Because a pulse oximeter monitoring will merrily go along measuring a relatively high pulse oximeter reading because carboxyhemoglobin and oxyhemoglobin absorb very similarly. So your pulse oximeter is not going to pick up the fact that this patient has a large amount of carboxyhemoglobin, but your blood gas will when it's sent through a co-oximeter, which separates oxyhemoglobin and carboxyhemoglobin and tells you the percent of hemoglobin that has carbon monoxide bound to it, or carboxyhemoglobin. A patient that has carbon monoxide poisoning, usually their minute ventilation doesn't change much, even though there's a lot of their hemoglobin that has carbon monoxide bound to it. Why? Because remember that the carotid bodies don't respond to content or saturation. They're responding to PaO2, and PaO2 is likely to be normal in carbon monoxide poisoning. So don't expect the patient to be hyperventilating a lot under carbon monoxide poisoning situations. How do we treat carbon monoxide poisoning? Give them a lot of oxygen, and hyperbaric oxygen can be used, especially in patients that are comatose, have neurologic abnormalities when they present, possibly if they have myocardial ischemia, if they're pregnant, if their carboxyhemoglobins are very high, like up in the 20 to 40% range. Lower carboxyhemoglobin levels are used as a trigger for hyperbaric oxygen treatment in a pregnant person. And even transfusion of packed red blood cells to provide oxyhemoglobin can be done. But usually the treatment is supplemental oxygen, get them out away from the source of the carbon monoxide, and hyperbaric oxygen in some situations. So hyperbaric oxygen indications is the next key word. Patients that have had air or gas emboli that went to their head, venous air emboli, cardiopulmonary bypass accidents, hyperbaric oxygen occasionally can be used. Carbon monoxide poisoning, especially in certain types of patients like pregnant and those with coronary artery disease that's severe and they're having angina because they have such low oxygen delivery to their heart, and who are having central nervous system dysfunction. Cyanide poisoning, remember cyanide poisons cytochrome AA3 or oxygen use at the tissue level. And the treatment for cyanide poisoning is things like thiosulfate, vitamin B12, amyl nitrite, which converts our hemoglobin from Fe plus 2 to Fe plus 3, or methemoglobin, which then can bind free cyanide and get rid of it from our body. But another treatment for cyanide poisoning is hyperbaric oxygen. Other things like gas gangrene, decompression sickness from diving, infections and wound healing, very severe levels of anemia in patients that refuse transfusion, for example, and central retinal artery occlusion are examples of indications for hyperbaric oxygen. Some complications of hyperbaric oxygen. One of the gaps in knowledge over the last several years on the American Board of Anesthesia published gaps in knowledge is that if a person develops a seizure while they're receiving hyperbaric oxygen, that's really usually oxygen toxicity, and the most appropriate initial treatment is just discontinue the inhaled oxygen, stop giving them such high concentrations, and they stop seizing. You don't usually have to give them a benzodiazepine or propofol or something to stop the seizure. Just reduce the FiO2. So to treat a hyperbaric oxygen-induced seizure, reduce the inspired PO2, don't decompress the chamber. They can get decompression sickness and barotrauma. Rarely is there any sequela, and it's not more common to have these HBO-induced seizures in patients with actual seizure disorders. When you give lots of oxygen to a patient, there are some problems with oxygen toxicity. One is if you expose a patient to oxygen at high levels for about a half a day or so or longer, their lungs can get irritated by that high concentrations of oxygen. They get tracheal bronchial irritation. They can have cough and complain of burning chest pain and even develop ARDS. In the central nervous system, they can get nausea, vomiting, numbness, twitching, seizures, and their eyes. They can get changes in refraction, myopia, narrowing of their visual fields, and this is all oxygen toxicity. Pulmonary embolism is the next key word. Number one symptom of pulmonary embolism is acute dyspnea. Number one sign is that the patient is breathing rapidly and is tachycardic. An arterial blood gas, usually you'll see a drop in PaO2, and the patient will be hyperventilating with a low PaCO2 when a pulmonary embolus occurs. On the electrocardiogram, if the pulmonary embolus is large and is blocking pulmonary artery blood flow, you can see changes on the right side of the heart, like a right axis deviation, and peaked P waves, or P pulmonale, lead to having a very high peaked P wave, right bundle branch block, and even atrial fibrillation. If a pulmonary embolism occurs during anesthesia, classically what you see is a sudden drop in saturation, the blood pressure drops, the patient becomes tachycardic, and you have a sudden drop in end-tidal CO2, let's say from 35 normal down to like 15 or 18, because what has happened is that pulmonary embolus is blocking blood flow to alveolar units, which you continue to ventilate. If blood flow is not coming back to alveolar units, bringing carbon dioxide, but you continue to ventilate the unit, the CO2 end-tidally drops, but arterially builds up. So the gradient between end-tidal, which is low, and arterial, which is high, widens. And if it's very bad pulmonary embolus, it can block blood flow out of the right side of the heart. Pulmonary hypertension can ensue, and CVP can be very high, and the right heart can fail. Diagnosis of pulmonary embolism is often done by CT as well as clinical findings, but a D-dimer blood test is one that can be used to show evidence of fibrinolysis that's occurring, and if D-dimer is high with these other symptoms present, and CT evidence of a thrombus sitting out there in the pulmonary artery would be classic findings in a patient with PE. Bronchopleural fistula ventilatory management is the next key word. A bronchopleural fistula is an abnormal communication between the bronchial tree and the pleural cavity, often an infection or cancers occasionally. Occasionally that connection can not only go from the bronchus out into the pleural, but all the way out into the airspace, go through the cutaneous layers and the muscle of the chest wall. The problem with this is that if you give positive pressure ventilation down a bronchus that has a hole into the pleura, without a hole out into the air space, then each breath that you give, some of the air may leak into the pleural space and cause a tension pneumothorax. So the anesthetic management of a patient with a bronchopleural fistula is, one, protect the healthy lung from the contamination from the damaged or infected lung, prevent tension pneumothorax that can develop with positive pressure ventilation, and there's the possibility of, if you try to ventilate a patient who's got that big air leak, air is going to go where the least resistance is. And let's say you have a bronchopleural fistula on the right side. Air is going to go down that right side, out the bronchopleural fistula, into the pleural space. And if you had a chest tube in there, the air could go out the chest tube, and there'd be very little air then that would go into the normal left lung and ventilate it. So you'd be losing inspiratory tidal volume out that bronchopleural fistula. CO2 would build up. So classically, we want to isolate the affected side to prevent contamination of the good lung and to allow us good ventilation of that lung that's not damaged. The gold standard is an awake intubation, a double lumen tube, keeping the patient breathing spontaneously, but other options include general anesthesia with a double lumen tube, spontaneous ventilation to avoid a tension pneumothorax, and unclamping the chest tube that is draining the pleural space so that gas cannot build up in the pleural space and develop a tension pneumothorax. Ventilatory management, double lumen tube with differential lung ventilation. So if you put the double lumen tube down and you have a bronchopleural fistula on the right side, you can ventilate just the left side and not the right side and let it heal over time. Keeping your tidal volume low and your airway pressures low are another way to try to prevent air going down that damaged lung and out the bronchopleural fistula. And high-frequency jet ventilation is occasionally used as a non-surgical option for large bronchopleural fistulas. Rheumatoid arthritis, what happens in the lung and the airway? You can have blockage of the small airways, bronchiolitis obliterans. You can have pleural effusions and lung nodules and even develop pulmonary hypertension. But one of the classic findings of rheumatoid arthritis is fibrosis of the lung. When the lung becomes fibrotic, FEV1 and FVC can both go down, and the lung have a restricted pulmonary function test pattern where the FEV1 over FVC ratio is still greater than 80%, but both are decreased. So restricted PFT pattern. And another thing that rheumatoid arthritis can do is cervical spine involvement such that the neck mobility is reduced, but also instability of C1, C2, which is atlantoaxial subluxation. And lateral x-rays of the neck in the flexed position can show you this atlantoaxial subluxation. For a rheumatoid arthritic patient, restricted lungs, cervical spine involvement is something you should think about. The next key word is near drowning, pathophysiology and treatment. When a patient is immersed in water, there's several things that can occur. One, they can have laryngospasm, which would stop fluid from going into the lung and just allow the fluid only to come into the oral pharynx or the larynx. Or sometimes when they go under the water, they will gasp and fluid will be sucked into the lungs. Now the type of fluid that goes into the lungs makes a big difference. If it's salt water, that's hypertonic. And if it goes into the alveolus of the lungs, the salt water will draw fluid from the bloodstream into the alveolus of the lungs. It actually can cause hypovolemia because intravascular volume goes down and all the fluids in the alveolus of the lung, and hemoconcentration. The hematocrit actually can go up. So salt water draws fluid into the alveolus, and it's drawing fluid out of your vascular space, so you can be hypovolemic and have all of this fluid inside the alveolus. In the freshwater case, freshwater is hypotonic, and so as the water goes down into the lungs, it's absorbed into the bloodstream and dilutes the red blood cells, and it changes the osmolarity and can even cause lysis of red blood cells because of the hypotonicity. And all of that fluid leaking into the vascular space can cause hypervolemia. So the saltwater patient drowning can be hypovolemic. The freshwater can be hypervolemic. CPR differs a little bit with near drowning in that Instead of oftentimes not ventilating right away, the classic arrest patient, if it's a near drowning patient, give them 2 rescue breaths first and then chest compressions if they do not respond. And this differs from cardiac arrest due to other causes, where CPR begins with immediate and uninterrupted chest compressions. A question as we end. 1 hour after administration of 2 units of packed red blood cells and 2 units of FFP to an 80-year-old intubated and mechanically ventilated patient for a Whipple procedure, you notice an increasing AA gradient and clear fluid coming out of the endotracheal tube. Blood pressure is 150/80, heart rate's 110, pulmonary artery pressure is 55/35, PaO2 is 80, and they're on an FiO2 of 0.8. Well, if you gave them 2 units of packed red blood cells and 2 units of FFP to this old patient, and they now have clear fluid coming out of the endotracheal tube, that's a lot of volume that they gave to them, and their pulmonary artery diastolic pressure is very high at 35. This is really hydrostatic pulmonary edema. Non-cardiogenic pulmonary edema would be a bilateral alveolar, fluffy alveolar filtrates bilaterally on your chest x-ray, less than 6 hours after a transfusion of FFP, packed red blood cells, or platelets, without elevated left-sided pressures. So non-cardiogenic pulmonary edema is TRALI. So the answer to this is hydrostatic pulmonary edema. This ends part 3 of a 3-part series on respiratory and thoracic topics. Hope that you keep studying and learning every day and that you have a great day. I love this quote: if you're not willing to learn, no one can help you. If you are determined to learn, no one can stop you. Picture on the bottom right is from the fall of 2017, where I had the opportunity to camp and bike along the Skyline Drive in Virginia and the Blue Ridge Parkway in the fall with the trees changing. It was very beautiful. Hope you have a wonderful day.